Mayo Clinic presents
Emergency Medicine Grand Rounds.
Hello, and welcome to Always On EM. My name is Venk Belamkonda. This is the mid-August Grand Rounds episode of our Emergency Medicine podcast from the Mayo Clinic Department of Emergency Medicine. It's been a while since we gave some shout-outs, and Alex and I wanted to do that like we used to when we first started this thing. We only get to see the names of the people who follow us on the Podbean platform, but first, thank you to everyone who's subscribing, rating, commenting, or just listening to the show on any of the platforms that you're using. Thank you to you and everyone around you that are doing that. Specific shout out, though, to Ahmed Maya for following us on Podbean. Also, shout out to one of our recent amazing graduates, Dr. Rebecca Leff, who you may have heard on one of our episodes earlier this year. She is now following us on Podbean. Thank you, and we hope that the world is treating both of you very kindly. We received some emails recently to alwaysonem@gmail.com, and we love hearing from you about your ideas, desires for content, feedback on what we're doing well and what we could do differently to serve you better. So please continue to do that. In particular, we are bouncing around the idea of offering continuing education credits for those of you listening to the show. We'd love to know how you feel about this change. Is it worth our time for us to invest to do that? Would you take advantage? All of your thoughts are welcome. We recently had a fantastic discussion with Dr. Lacey Hsu about some regional anesthesia practices that you could bring to your next shift. And then this month's core episode was on anaphylaxis, specifically related to contrast-induced anaphylaxis, and had some fantastic pearls from Dr. Ronna Campbell. So if you're behind on some episodes, make sure you go back and get caught up when you have a minute. Maybe you're out walking the dog in this beautiful end of the summer period, or you're hanging out by the pool, or whatever you're doing, taking a great hike. Get caught up. Finally, as medical students throughout the United States begin the process of away rotations and interviews, if you're listening and that's you, we just want to wish you well on this exciting new phase. Remember to do your best and have fun meeting all the different patients and teachers. Try and learn as much as you can from everyone. And try to focus on representing yourself as well as possible rather than trying to fit what you think that the people around you want or the residency wants from you. That's the only sure way I know for you to be able to sleep well at night, no matter what happens. In the end, you want to be in a place that sees you for who you are and is excited about you, wanting to help support you when you need it and the areas you need it, as well as let you fly in the areas that you're ready to fly. So, best of luck. Feel free to reach out to Alex and I with anything that you need from us or that we can help you with. And please check out our residency here in Minnesota in emergency medicine. We would love to see you and be able to meet with you in person and see if this is a good fit for you and if you're a good fit for us. So check us out. Okay, now to today's show. This is a great episode for several reasons. There is bread and butter disease being rethought and reimagined for today's health constraints. And this show shows how we should continue to look at even things that seem so well codified to see how we could do them better and more efficiently. Also, as Dr. Carpenter will outline at the very end, this is a mental inspiration for us all to think about how we can battle overcrowding and access to inpatient health resources for our communities and patients without having to wait for the hospital to make the changes first. We ourselves in the ED can be part of the change or influence or drive that change, and we can all benefit in the community. For these and many more reasons, I'm excited to share a talk from this past winter when we had the amazing health quality leader, Dr. Rich Griffey, join us in Minnesota to teach us. He's being introduced by Dr. Chris Carpenter, so grab your popcorn, a soda of your choice, and as always, thank you for listening.
It's my pleasure to introduce Dr. Griffey. Rich and I worked at WashU together for 15 years. He's the professor and vice chair for quality and safety in the Department of Medicine at WashU. He completed a residency at the Harvard Emergency Medicine program at Brigham and Massachusetts General in 2001. Got an MPH from Harvard School of Public Health in 2004. He also completed the Patient Safety Fellowship with the National Patient Safety Foundation and the Institute for Healthcare Improvement, and got a KM1 award in comparative effectiveness research. He served on the faculty at Brigham and Women's until 2007, and then joined Washington University as the Associate Division Chief of Emergency Medicine and Course Master in the WashU Institute for Public Health. He's held multiple leadership roles in the quality infrastructure of the American College of Emergency Physicians, including chair of the Quality Improvement and Patient Safety Section and Quality and Patient Safety Committee. His research interests include adverse event detection, organization of ED care, health communication, evidence-based imaging, and implementation science. He's authored over 100 peer-reviewed manuscripts, editorials, and book chapters. He serves on the editorial board of Academic Emergency Medicine and is a grant reviewer at HRQ and a reviewer for multiple journals. He's a principal investigator of an HRQ-funded R18 and R01 to develop and validate ED trigger tool for detection of adverse events in ED. And today he's going to talk about something that we see pretty much every day in the emergency department, and that's management of the DKA patient. We all know that pretty bad boarding problems going on, and any patients that we can save an ICU bed for are going to be really helpful for us to get another patient out of the waiting room and up to the floor. He's got some fascinating work underway to develop reporting standards for adverse event reporting, and I think you'll find a very rich repository of information for quality patient safety. So thanks for coming.
Thanks for having me. I've never been here before. It's I'm saying it's a balmy 33 today. So my main interest is in quality improvement and patient safety. And this work was sort of born out of some observations of quality issues we had related to DKA and patients going to the floor and opening up a gap and, getting feedback on that and trying to improve. And we kind of tightened our approach to standardize our approach to DKA management. And then this was sort of work that built upon that. So I'm going to talk to you today about what we call the SQuID protocol, subcutaneous insulin in diabetic ketoacidosis. And our first round of that, and then our follow-up study is called SQuID. And it was expanding upon that and built in some additional outcome metrics. So I have some grant support from HRQ and from our hospital foundation that helped fund this. And so, as Chris alluded to, here's the problem. So we have these patients who are in diabetic ketoacidosis. They're really not the sickest patients usually. They're deprioritized for the ICU because their sicker patients need those beds. We personally, I know you guys have some sort of intermediate care beds, some step downs, and whether or not you have access to those is a separate issue. But we don't have those, and so the protocol tends to be that we keep these patients in the emergency department. We keep them on a drip, and they wait in the ED for hours on a drip until their gap is closed and the drip discontinued, and they're observed for 2 hours after that, and then they're okay for the floor. And so we're not allowed to use insulin on the floor, which is understandable. Insulin and heparin are both high-risk medications and account for the majority of adverse events you see, medication-related adverse events in the ED, in the hospital. And so that's generally not permitted on the floor. I understand that here you can do insulin on the floor, which, is nice. And in the ED, these patients, DKA it's very algorithmic driven, and it does require close attention to detail. And when you have STEMIs and strokes and traumas coming in, it's very hard for the nurses to do all of that and do it reliably for hours to get those patients taken care of so that they can go to the floor. And so that was really the impetus for this project. And we didn't invent a sub-Q protocol. It's been around, but I learned about this possibility, and we thought, maybe there's an opportunity to do something different for these patients where we avoid the insulin drip and we could get these patients admitted to a non-ICU setting. So, the advantages of sub-Q are that you can do Q2 rather than Q1 hour finger stick glucose checks, which I'm not sure if that's the case here, but for us, that's if someone requires Q1 hour just about anything, then they go to the ICU because it's at the scope of what the nurses can do on the floor. It avoids the insulin drip, and it avoids having to go to the ICU. And so, just by way of refreshing your memory, so the short-acting insulin analogs like Aspart and Lispro have peak just under 2 hours, and the short-acting insulin, like regular insulin, has a similar profile in terms of the peak, and then the glargine is a long-acting with a lower ceiling. So there are a number of studies that have looked at this, but they all tend to be pretty small sample size, like 20 to 50 patients. And Perez, who was an endocrinologist in Memphis, I think, and then I think maybe been at Emory for a while, did a couple of these, a single center or multi-center with some different arms in terms of the dosing. And then there have been 3 other studies in Brazil and Turkey and India, and one in Iran, where they've done studies in adult and pediatrics. And I'm not going to go into the details of these, but they all demonstrated good efficacy and often similar times to treatment completion, a gap closure in DKA with good safety profiles relative to IV insulin. So there's a Cochrane review on this, sort of believe it or not, and the outcome of that was low. It was, the studies were low to moderate quality, just because of the size, I think, more than anything else. And there've been a couple of reviews in the EM literature looking at this as well. And as I noted, that the quote here was that they suggest no difference in the duration of therapy or safety. With this in mind, we started our project with the assertion that this is known to be safe and efficacious care. And so we partnered with our endocrinologists and with our hospitalists and with hospital and ED nursing to initiate this protocol. We looked at all of these studies and came up with what we thought was the best protocol, a very conservative protocol for our use. And when we got this approved through the IRB as an alternative care pathway. So we were not studying the efficacy of this. We were studying the outcomes and impacts on ED operations as our primary outcome. We had to get it approved through multiple committees and multiple diabetes committees in the hospital. And it had to do a lot of education, both for the ED and for the floor. For the ED, this was kind of new. There's a lot of protocols in the hospital where nurses follow an algorithm and titrate medications based on the algorithm, but we didn't have a lot of that in the ED. And then for the floor, at least in our facility, all these patients would either be fixed in the ED already, or they would have gone to the ICU. So for floor nurses, they were not used to seeing patients with DKA. They just hadn't managed them before. So all of that education was very important. And then our outcome measures were these 3 here. Were fidelity. We wanted to demonstrate that we were doing what we said we were going to do. And this was pretty down and dirty. It wasn't a robust evaluation of fidelity. So it's, did we do the blood glucose checks every 2 hours as we said we were going to do? And safety was, how often did you have to give rescue dextrose for episodes of hypoglycemia? And then our operational metrics, the primary outcome was ED length of stay. And we also looked at ICU admission rate. All of our data was kind of electronic data capture. So we didn't do any manual review for this except for data integrity checks. We just pulled it, retrospectively through our EMR. And we looked at year, like end over end, year, not year, but actually, I'll show this in a second. For our ICU admit rate, once you do your intervention, we had to have a comparison group. So we looked at prior to intervention and then prior to COVID, because this happened during the COVID period. And we wanted some kind of comparison about how we looked at, compared to historical controls. So we had some pretty standard exclusion criteria for studies looking at management of DKA. So if you're pregnant, if you're under 18, and I'm not going to read all of these to you, but I think probably the most important one here was this last one, because when we put the protocol in place, you couldn't just send a patient to any floor, because that would have been a lot of training for different nursing staffs all over. And they would never get the volume, so they wouldn't have the competency to do it. So everyone was cohorted onto one floor, which was the one we could only bargain for to get, and it was an inpatient obs unit. So these patients, if they were too sick for that floor, if you thought the patient wasn't going to make it out within 24, 48 hours, and they had other stuff going on, then they would be ineligible. And so in some ways, you'll see later that it's a bit of a foregone conclusion that if you have these shorter stays and these patients are less sick, that you might expect that you're gonna have improvements in ED length of stay and getting them out if they have a dedicated place to go. But that notwithstanding, this was still sort of a proof of concept that you could do this.
Rich, was that last criteria just subjective for the physician and nurse?
That was subjective for the physician. Yeah,
The admitting physician and the
usually ED physician. Yeah. So this is a sort of standard ADA, American Diabetes Association, severity index. The relevant, all of them are, over 300. So if you have a pH of less than 7, then you're severe DKA. If your bicarb's less than 10, you're severe DKA. And so those people would be excluded from admission to a floor. Anyone who's in severe DKA would just go to the ICU, but the other patients would be eligible. And so here was our protocol. When a patient comes into the ED, and some of this predated this study, when a patient comes into the ED, they're asked whether they're diabetic, and if they answer yes, then they get a finger stick blood glucose check. And if that's 300 or greater, then they get a point of care blood ketone test. And if that is 1.1 or greater, then they're ketotic, and that launches BPA and EPIC for the nurses, and they have some standing orders. They order a VBG, and it also and some other blood work sends a BPA to the physicians to this patient may be someone in DKA, and the labs are pending. So sort of be on the lookout for them, and it prompts them to order a fluid bolus. So when we use that prior severity index, and it pulls the labs in automatically and calculates for you whether the patient is by labs mild, moderate, or severe. So if it turns out that they're not in fact acidotic, then you might get a BPA that shows you this person's not in DKA, and so they're out of the pathway, right? We do see some odd cases of either euglycemic DKA or people who were maybe early DKA, but they haven't really become acidotic yet. And so had to be, for the purposes of the study, had some distinct cutoffs, but in clinical practice, there's a little bit of leeway in this regard. So if you were severe, you have to go to the ICU. And if you are in mild to moderate DKA, then it displays these different exclusion criteria. And if you don't have any of those, then you are eligible for SQuID. And so if you're on SQuID, then you get started on this protocol, and you can put the mission bed in right away and get that patient. They continue on the same protocol as an inpatient. So sort of seamless in that regard. Although even with this protocol, sometimes there's not beds available there, and a patient may end up waiting in the ED for a while, even for a SQuID bed. So here's our protocol. So if you looked at that table of those prior studies, there was a number of different either dosing or bolus dosing or timing changes. We picked what we thought was a pretty conservative approach. So 0.2 units per kilo bolus, and then 0.2 units per kilo for subsequent Q2 hour administrations if their blood sugar is still greater than 250. And then an adjustment to 0.1 unit per kilo after they're less than 250 and on a dextrose-containing fluid drip. And we got chicken, and so we made a cap. Our max was 24 units, just because it makes me nervous giving someone a bolus of 30 units of insulin. So, that's a little bit arbitrary, but that's the cap that we put in place. And the control group, the regular insulin protocol, is pretty typical, I think, of what most places use. So 0.1 per kilo bolus and a 0.1 per kilo per hour drip, and dextrose once you get to 250, and then we have some titrations in there for the nurses to use for different blood glucose ranges. And all these patients get a 2-liter bolus up front, unless you're an end-stage renal, end-stage renal failure, or if you have congestive heart failure, you can reduce that.
Were
So,
some people excluded in the first place? So
beg your pardon?
exclusion criteria, the heart failure and the.
you should be,
Anyway.
yeah, you should be. I mean, I guess if you had some kind of concern for AKI or something, but you're right, they should be excluded. So our analytic plan was for the post-intervention period, from the time of the onset of the SQuID protocol going forward. We compared the IV versus the SQuID patients, looking at fidelity and safety and ED length of stay. As I just mentioned, sorry, this gets cut off. We had a very early on, we had to throw out some people who were misclassified, and they were started in the SQuID protocol, but they were actually too sick and they got transferred over to IV. But we had, pretty decent numbers in these groups, and those were our control groups for pre-SQuID and pre-COVID. So our results were, we had less than, it turned out, I was kind of surprised, less than 1 hour timing for blood glucose checks, can normalize for their ED length of stay. So they had to have at least 1 blood glucose check per hour. It should have been, we were aiming for better than 2. It was just slightly under 1. Although we weren't powered to detect, safety events, we didn't find any difference.
Hi, this is Venk jumping in. Right here, we lose a couple seconds of Dr. Griffey's audio, but we'll jump right back in, and he hasn't even switched slides. Just to set the stage, the slide that he is referencing right now, when the audio cuts back in, has some data on it. There's impact on ICU admissions, pre-COVID, 49.1%, pre-SQuID, 46.0%, post-SQuID, 42.9%. Okay, I'm going to jump you back in.
Adverse event usually requires a huge amount of power because they're pretty uncommon. So we didn't find any difference in groups in safety. And in this first part of the study, with the numbers that I just showed you, we did not have sufficient power to demonstrate a reduction in ICU admissions. And you kind of wouldn't expect that, because if you're only plucking off the mild and moderate patients to be in the SQuID group, it's really not going to impact those severe people who would have gone on to an ICU. So these are B-swarm plots, and you can see our reductions comparing the SQuID and the IV group. We had a reduction of 3 hours in ED length of stay. And when you compare that to the ED length of stay prior to the pre-intervention period or pre-COVID period, we had reductions in both of those. And the graph on the right is this just a different way of displaying the same data. So we published this in academic EM, and we won a team award in quality improvement at the hospital. And so we got picked up by a few Journal Watch and podcasts. And so we're pleased that there was some interest in this. And the limitations in this study, like I mentioned, it's you would expect that if you have this population that is easy to admit and they're lower severity, that well, of course, you're going to have a lower ED length of stay. And but we weren't prepared. I mean, we didn't want to randomize patients to this because we weren't really looking at efficacy. We were looking at what are the potential impacts of implementing a protocol like this. What could it do for us in terms of saving patients time in the ED and opening up ED beds? The other thing is that during COVID, there were very odd things that occurred. At times, like the target floor where we would admit these patients was designated as a COVID floor, so we just couldn't get patients there on SQuID unless they were SQuID plus COVID. And there were times when we had no ICU beds, and then there were other times when we only had ICU beds. So it was an odd time to do studies like this. And I think in general, this blunted the magnitude of the effect of our results. We felt like we demonstrated that it was effective, and even though that wasn't a primary outcome, like all these patients got better. We had equivalent safety, and we were able to reduce ED length of stay. There was this trend towards a reduction in ICU admission rate, and I'll show you our subsequent data on that. We learned that partnership and education are really important for projects like this, and we had to kind of monitor often for how physicians were using this, because I think early on people felt like if they wanted to give a sub-Q dose of insulin, they would try to pop onto the order set and use it, but then not do all of it, or they would start someone on who really wasn't appropriate and should have been excluded. We didn't find that many missed opportunities. I think emergency physicians were very much on board with, hey, I can get this patient better and get them out of the ED faster. And so it sort of like made a case for itself. As I mentioned, there were those different aspects of nurse education that were important. In general, we were pleased that there's an appetite for people to implement something like this. I get other hospitals in our healthcare system reached out to see if they could use the order set. And I said, well, it's not really just an order set. It's a lot of other stuff that goes with it, but we're working towards that in a few of them. And having a silly or catchy name helps get your project known about and accepted. And we also had a number of questions that we didn't answer that we thought would be interesting to follow up on. One of them was, in some of the comments of some of these journal feeds, I sort of trolled through the comments that people put in. And some people said, well, I'll wait until there's a little more data on efficacy before we put this in place. And we were wondering, whether I really didn't like the idea of just limiting this to a single observation unit in our hospital, but I do recognize the importance of nurse education and maybe cohorting these patients. I wouldn't want to just send them to any floor and the nurse is like, I've never cared for DKA. What do I do? What is this SQuID protocol? What are we talking about here? And we know that in the ED, our staff seem to really like SQuID, but how do the nurses feel? How do the nurses on the floor and how do the doctors feel? What about patients? Does it matter to them whether they're getting Q2-hour sub-Q injections versus a drip? And are there modifiable factors that we might be able to identify that could prevent DKA in the first place? And so, that prompted our second study, the SQuID study, and we got another hospital grant for this. And the E's were expansion, efficacy, experience, and equity. And so we expanded our protocol to include another floor, like a regular medical floor. And this also allowed us to take sicker patients who didn't have to meet the standard of being there for 24, 48 hours. It also gave us an opportunity to potentially demonstrate an impact on ICU admissions, because now it could siphon off some people who might otherwise go to the ICU because they can't go to the floor. And we had, instead of electronic data capture, we had people doing near real-time record reviews to look at specific metrics like time to gap closure, time to glargine administration, et cetera, et cetera. And then once the anion gap closed, they would contact patients on the floor, usually by phone, to assess their satisfaction with sub-Q insulin or IV. And we used these different, we have a tool I'll show you in just a second, one for patient satisfaction and one for gathering social determinants of health data, and another for the brief health literacy questionnaire. And then we assessed staff satisfaction as well. So when someone cared for a SQuID patient, we would receive a list every day of those patients, and we would review the record to see who was the doctor in the ED and the resident in the ED and the nurse in the ED, and then on the floor, the hospitalist and the resident who cared for the patient like the most. And we would send them the questionnaire by email. And so that's how we got those data. So again, our outcome measures for this were, one was on an efficiency, and those were, again, fidelity. But instead of blood glucose, we looked at time to glargine administration and time to dextrose containing fluids administration. And then efficacy was time to anion gap closure and total time on protocol, which are some standard metrics that are used in studies of this type. And then efficiency was time to bed request, which was hoped to offset the boarding issue. So if everyone's boarding a whole lot, then your total ED length of stay is less good of a metric for looking at impacts of an intervention like this, potentially. So as far as the patient satisfaction goes, we used a tool called the Diabetic Treatment Satisfaction Questionnaire, inpatient version. And this is a proprietary tool that was developed by this British group. And it took me many hours to get their approval to use their tool. And I'm not allowed to disclose, the items in the tool. And so it's a 20-item questionnaire with a sort of composite metric that evaluates a patient's satisfaction. I think it's proprietary because I think they farm it out to big pharma companies who pay to use the tool to compare different, if you're on, drug A versus drug B. And for the staff acceptability, we used a tool called the Theoretical Framework of Acceptability, and it covers these domains there over on the right. And here's actually the questions that we used on the left to ask staff. And so the staff would, nurses and doctors and residents, and would receive the email with a link to REDCap. They would receive the questionnaire, and if they complete the questionnaire, they would get a SQuID t-shirt. Or SQuID socks, I think we had. We then used the CMS has a 26-item social determinants of health inventory that covers these 13 domains. And we would ask these patients those questions. These are 3 self-reported brief health literacy items that have been used in various health literacy studies and have actually been shown to be pretty useful, although a lot of health literacy researchers don't like self-reported metrics in general, but they were easy to collect. And so, here's our results. This is our population. This is from March to December, and this study's ongoing. We're hoping to enroll ultimately up to 400 patients, although I have to say that, prior to COVID, we had 6 to 10 patients in DKA per week. And 2/3 of those were mild to moderate in severity. And those numbers have really dropped off, surprisingly, during COVID. And then afterwards, our numbers are not nearly what we actually had a couple weeks ago, we had a no-hitter. And for us, that's very unusual. The male-female was pretty balanced in the SQuID group, a little bit different in the IV group. We have, a majority Black African-American population in RED. And you can see the group here. These were, this is just sort of all DKA patients, mild, moderate, and severe. And you can see that we've had, really only had 6 patients in the traditional group who are treated with IV insulin in the ED and then admitted to the floor. We've really had a big shift now so that almost everyone who doesn't go to the ICU is now on SQuID. And of the patients who don't go SQuID, they almost all go to the ICU. So here's our fidelity metrics, time to Lantus, and that should say, well, Lantus and glargine. So time to Lantus and time to dextrose containing fluids. And these denominators this is for both, because our denominator is 6 for the patients who were treated and go to the floor. We included the mild to moderate patients who went to the ICU. So that's our comparative group. So you can see our median numbers are doing better for the Lantus and are pretty similar for the time to dextrose. and our efficacy metrics, time to anion gap closure and time on protocol. We outperformed the time to anion gap closure, time on protocol. It's pretty impressively tight there for the SQuID group. We broke this out by comparing for efficiency. This is just those comparing against those 6 who went to the floor. So you can see our ED length of stay for those patients and our time for bed request are both lower for SQuID. And oddly, when you compare to when you combine floor and ICU, during this period, we were able to get ICU beds pretty quickly for the patients who were going to ICU. So our numbers were pretty equivocal for these. Our patient satisfaction composite score was equivalent for both groups and it was high. So no real difference there, which I'll take as a good thing. That people at least weren't unhappy with getting sub-Q injections compared to a drip. And we had a good response rate for our survey, like 80% response rate. You do have some hospitalists who are, fellows who are doing a year or something and maybe a little less engaged. And so our response rate for them was probably a little bit lower. And our acceptability metrics on the theoretical framework for acceptability were all highs. I have these columns broken out by the respondent type, and then the second column for each one was the proportion that were 4s or 5s. So it's Likert style question, negative being 1 and positive being 5. So probably the one anomaly there, as you can see for floor RNs, when they assessed burden, they had a 2 was the median number. And I think, again, that's because they never treated patients with DKA. They're there on the floor and like, all of a sudden I've got to do this thing. And even though it's probably easier than having someone on a drip and doing Q1 hour checking, they didn't have any frame of reference. And I think it was more burdensome for them to care for these patients than maybe for some patient who doesn't have DKA. So that was kind of interesting. And we found that like 100% of the patients we evaluated had some kind of social determinants of health need identified. And of these top 5, over 50% had the top 5. So we're kind of interesting, physical activity, financial strain, mental health, food insecurity, and substance use. So we're in the process now of we're starting to gather these same data on patients with type 1 diabetes in the ED who are not in DKA and who haven't been in DKA for the past year. And we're going to use that as a comparator group to see whether there are certain ones of these that are unique to patients with DKA to form the basis for potential interventions to try to prevent development of DKA. In the larger, other studies of patients with DKA, medical noncompliance is usually the reason for their going into DKA. And so, I'm not sure if that's financial strain is a part of that or what it is that will tease out to be the most important for something modifiable. Of course, with the numbers that we've seen, maybe they fix their own problems since we're seeing fewer and fewer of these patients. So maybe it's going away. Our health literacy numbers were surprisingly high. I've done prior health literacy research in RED and the prevalence was pretty high. And so, again, these are self-reported data, but for these patients who largely have, who all have some SDOH burden, those are pretty high health literacy numbers for a group where over 50% have these 5 major problems. And then finally, I wanted to show you the updated data on our disposition. So the blue line there, and these are lowest curves, so they skew a little bit, but you can see that, almost anyone not in the red, and anyone not going to the ICU is now default treated with SQuID. And the green, although it loops up there at the bottom, we haven't had, like I tell you, that we showed you that there's 6 cases that were in the group that were treated in the ED and went to the floor. This gives you probably a little bit, it's less pretty of a curve, but probably the green one is a little more realistic in terms of the numbers there. So when you expand the time frame, we've in fact, from the time that blue line was initiated, you see a big change in the disposition of these patients, so that all of them essentially are going on SQuID if they're not going to the ICU. And when we've done looks at patients who went to the ICU, they're almost always patients who really require the ICU for a reason other than DKA. They were also septic or, had some kind of surgical infection or something. So, from this study, we found a high level of fidelity with SQuID. We found it was equivalent to or outperforms the efficacy of IV insulin. We found this was very efficient, although with some caveats about bed availability. Some of the patients going to the ICU can get there faster, but for when you look at going to the floor, we still see a good effect in terms of ED length of stay. We had great level acceptability for nurses and providers of all types. And our patient satisfaction was high and certainly not below that for the IV cohorts. And then we found there's definitely some kind of opportunity there in terms of social determinants of health, and more to come on that as we tease that out a little bit more. We're surprised about the high level of health literacy that was measured. And you can see that over time, we've definitely demonstrated a reduction in ICU admissions, which is a nice hook for the hospital in trying to get further funding to try to expand this to other floors. So we're continuing enrollment now. We're adding a control group, as I mentioned, for the SDOH data. We'd like to add some patient incentives to get those patients who drop out of some of the, it's a lot of questions to ask somebody in a 10-item, satisfaction and a 26-item SDOH. And some patients are like, yeah, I'm done. I don't want to do anymore. So maybe an incentive would help. We're thinking about maybe trying to expand this to some kind of multi-center study, probably focusing on like a hybrid effectiveness model, since we feel like there's already some effectiveness data. And we're looking into things like continuous blood glucose monitoring in the ED. In the hospital. It's recommended for outpatient use already and FDA approved. It's not FDA approved for in the hospital, and there's no interface between the app that these things use and say Epic, which would be like a big opportunity to pull those data in, and you might really be able to impact inpatient hypoglycemic or glycemic control and reduce hypoglycemic episodes. Like I mentioned, we're working with social work, and we'd like to try to really come down on some potential interventions to prevent DKA formation. And we're piloting this virtual nurse program. It's almost like a nurse consultant. So, we have an EICU, and, it's sort of the eye in the sky that looks at the ICUs and calls someone that says, hey, your patient in 5 looks like they're decompensating. You need to do XYZ. They're rolling out this program now with a virtual nurse so that if you, for example, sent a patient to a non-cohorted floor, that maybe there would be a nurse consultant who could say, oh yeah, sure, I have the SQuID protocol in front of me. It's one of the things we trained on, and I can kind of walk you through it if you're not familiar with it. So we'll see if that flies, and we'd like to take advantage of something like that so that we can expand this in a way where we're not, when we expanded this to include additional medical floors, we found that the turnover on that floor is low. And so the bed availability is low. And so everyone gets pushed to this observation unit, whether they really meet the criteria for that or not. Even people who are there pushing up against that 48 hours. The hospitalists like the protocol, and so do the floor nurses. And so they're push them to there anyway. So, and if you don't get enough volume, competency is hard to maintain from the nursing side. I'd like to acknowledge our team, my co-investigators and collaborators, and our residents and nurses and patients who helped with the study. So thanks very much, and happy to try to answer any questions you may have.
The reason I wanted Rich to present this is because I know we're all frustrated with boarding, that in our careers, that's only going to get worse. I think we're not going to build more hospitals. We're not going to build bigger hospitals. I think that there are opportunities for us proactively in the emergency department to do something about boarding. This is one example where we see something we see frequently, DKA at WashU had always got admitted to the ICU. There's no ICU beds most times, and there's an opportunity to admit them to the floor where we do have some beds and decompress the emergency department a little bit, shorten the ED length of stay, hopefully get more patients in the waiting room back to a room. I think there's other opportunities in emergency medicine to think outside the box, do things differently, decrease admission rates, admit patients less to the ICU, decrease ED length of stay. Some examples that come to my mind would be all the fractures we see doing regional anesthesia rather than procedural sedation. Probably cut about 2 hours off the ED length of stay if we do that well. Delirium patients, the older adult population that I study, if we're able to recognize delirium in the ED rather than when they get up on the floor, we probably cut about 2 days off their hospital stay just by recognizing it in the ED. So I encourage everybody here to think, and maybe Rich has some ideas too, where are some low-hanging fruit areas where proactively we can start to solve some of our boarding issues and not wait for the hospital and patient services to fix them for us.
Yeah, I don't I hadn't really thought about that about specific conditions, but I don't know if you have an observation unit. We used to have an observation unit in the ED, and so there's a lot of people managing chest pain as sort of a classic one, low risk chest pain, or TIA, seizures, things you can accomplish in a brief time in a short stay environment and get the patient through the system faster. And and we tend to do it better in emergency medicine than other specialty managed observation units. We no longer have an observation unit, but it's still an opportunity for the hospital to do that in an observation setting. Yeah.
Thanks so much for the talk. Really very inspiring to see something that, it's a very dogmatic approach that we have to DKA, and here you kind of re-envisioned it. And as you mentioned, there's some low-level evidence that's out there to support what you're doing, but it looks like really had to sell a lot of people on the new vision. And so I'm wondering, can you talk about the change management around that and just how you got everybody on board?
Yeah, it's a good question. There was something I read, something about, by the time you see like a musical act, like a band who's popular and they're like an overnight success, there's usually like 10 years that went into them grinding it out before they got there, right? For us, it was, I think one of the biggest things was finding a spot. We really didn't want to do it in the observation unit in the ED, and we were in the course of losing that obs unit, and the medicine service opened their own that was sort of competing, and the C-suite of the hospital didn't want to maintain an observation unit in the ED. So that wasn't a good spot for us, and so we had to really get someone from the medicine, and especially the medicine nursing side, to sign off on where can we send these patients. And I knew that over in our children's hospital next door, they would care for DKA all the time in a non-ICU setting, and they called it like the sugar floor. And so I was like, why don't we have a sugar floor for the adults? So this was an opportunity that came up, and in the course of, from the time we really came up with a plan to when we executed it, we probably had gone through 2 or 3 different nurse managers who had come along. But we were able to get that buy-in, and then we got like a foundation grant from the hospital. And beyond that, I think the ED is very open to new things like this. It's often other services, and having an endocrinologist on our team was very helpful. We had a few, we have some great endocrinologists, and especially some of the younger ones, a few of the crusty older ones who were like, had to take some convincing. And also pharmacy really helped us with making the case for doing this, and helped us navigate some of these many hurdles, the meetings that we had to get through to get it put in place. Once we had that going, we were good, and then our nursing leadership, and we had good nursing partnership on the floor, and that education went really well. And after we had the first few cases under our belt, people really liked it. Yeah.
I have a few questions. One, someone from a rural area, so I'm just kind of curious, maybe a long-term, how transferable this kind of protocol is and the training to more low resource settings? Because obviously if we don't even have to transport those people to an ICU at a bigger place, that's also a huge victory. Because those people have a hard time, they're waiting often as that competition space sort of heats up. And then my other question was just, as CGMs have become more accessible and popular, one, I wonder if that's part of ideally why some of the frequency has gone down, but have you matched that up with anything related to like the SDOH type of stuff? So those who do or don't have CGMs, what is their health literacy and what is their financial situation? And I don't know, I just wonder if those might.
Yeah, we didn't really collect data on CGMs this first go around. I found out that our endocrinologists had this stash of CGMs that they will give patients on discharge. And I believe there are federal programs maybe that, well, I mean, because it's recommended that it's something that people can get access to. But again, it's completely unstudied as far as I know of, and not FDA approved in the inpatient setting. Actually, who gets those and whether that contributes or not to development of DKA, it's good thought. Yeah, and I don't, I hadn't really thought about the critical access rural hospitals and having to transfer patients in DKA, but I don't see any reason why you couldn't, again, it's really algorithmically driven and not rocket science. It just takes attention to detail. And I don't see any reason why you couldn't, especially for patients in low to moderate risk DKA, severity rather, that you couldn't manage those in those kinds of settings. I mean, we're sort of accumulating proof that you can do that in like in an observation unit. So if you can do it in an observation unit, then you could do it in a critical access hospital for sure.
Well, thank you everybody for coming today. Rich, ever since I've known him, since he arrived at WashU, has had the silver hair. He earned his nickname at WashU, the Silver Man. I really think the Silver Fox has wisdom, so I know today. Thank you.
Thank you, Chris, for inviting Rich to speak with us, and Rich for sharing the amazing work that you and your entire team and hospital have done. Please take a moment to like, follow, and comment about our show on whatever platform you wish. Check out our social media feeds on Instagram or email us at alwaysonem. Lastly, if you've been considering attending the High Performance Teams Conference, there are a few openings last time I looked at the list, and so visit ce.mayo.edu and search High Performance Teams to register. The conference is in September 19th to 20th in San Diego at the beautiful Sheraton San Diego Hotel and Marina, and is being co-sponsored by Mayo Clinic and Stanford, so check it out. All right, that's a wrap for the show. We appreciate you very much. Come back September 1st, 2024 for the next episode. Thank you so much for listening.
The Always On EM Podcast.
Emergency Medicine Grand Rounds.